Thank you very much, and thanks the organizers to organize this pediatric session, which I always like the most. So the title of my presentation is Advances in the Management of Juvenile Idiopathic Arthritis. In this session, I would like to share some of my views on the, let's say, recent advances in the management of juvenile idiopathic arthritis. I would like to touch a little bit on the disease classification, on the concept of earlier use of biologic agents. I will discuss some new treatment options for juvenile idiopathic arthritis, and at the end, a few words on the early patient stratification, predictive biomarkers, and non-pharmacological management. At the beginning, I would like to share these slides showing relevant time points. And if we look at the first column, this first column is actually about the disease taxonomy, disease classification, identifying what type of subset of juvenile idiopathic arthritis the patient has. So this is even occult disease before the disease become overt and the patient got diagnosis. But when the disease is active, the patient should get diagnosis. The second column is when we are deciding which treatment we will give to the patient. So this is the early use of biologics. If we will use the right drug at the right time for the right patient, we will achieve clinically inactive disease or even disease remission. If the drug will not be partially responsive or not responsive, the patient will have kind of an active disease and could cause disease damage. So the second column is about the prediction of treatment response. And the third column is actually the column when we are deciding if the inactive disease will stay in inactive state for a longer time, so that this will be a sustained remission, and it's actually prediction of relapse risk. So these are the three critical time points. Regarding the definition of juvenile idiopathic arthritis, we all know this definition, which was somehow adapted with the Printo classification criteria, that juvenile idiopathic arthritis is not anymore arthritis, but is a group of inflammatory disorders. But we said, okay, we will keep the name juvenile idiopathic arthritis, but the concept is that this is a group of inflammatory disorders. And it was kind of based on this classification, the proposal for the Printo, also we know, tried to approach a little bit the adult classification, with systemic JIA being the counterpart of Still disease, rheumatoid factor positive juvenile idiopathic arthritis being counterpart of rheumatoid arthritis, and enthesitis spondylitis-related arthritis, counterpart of ankylosing spondylitis. But then it was a large group of actually patients that were unclassified and early onset ANA positive JIA that was not quite well defined. For those of you that were not at the press congress recently, there was a big debate about the updates of classification. It should be clinical or should be biologically markers based. And Ray Young presented these data that were not published yet. These are data based on the 600 non-systemic JIA patients who were prospectively recruited in these patients. And these patients were somehow analyzed with system biology approach regarding the clinical features, involvement of joints, and biologic features. And they were able to identify in an unsupervised supervised manner 5 clusters of this disease. One is juvenile axial spondyloarthritis in the red column with HLA-B27, presence of HLA-B27 present in older boys, which is quite well-known disease. On the other side, you can see juvenile rheumatoid arthritis, rheumatoid factor positive, which is also kind of the group that we knew even before. But very interesting, 2 columns that were first time reported are patients, a subgroup of patients with early onset polyarthritis, particularly younger girls with high interference signature and polyarticular involvement with wrist and toes. And in the blue column, you can see early onset oligoarthritis in younger boys and girls. Mainly more than oligoarthritis, monoarthritis like a knee monoarthritis in group patients, and then was one group of patients with juvenile peripheral spondyloarthritis linked with enthesitis. We are expecting soon also publication of this data. The thing is, and you will see also in the clinical trials that were used, we as pediatric rheumatologists, some are more kind of biology-based and would like to subclassify disease based on the biological features. The thing is that on the other side, you know, that clinical trials were conducted not even in a JIA subsets, but in a polyarticular course, juvenile idiopathic arthritis, which is combining different disease subgroups. So it really depends what should we aim our classification to somehow classify the disease biology, or to somehow try to get new drugs in our subgroup of patients. So the second part of my talk will be on the earlier use of biologic agents in polyarticular JIA and systemic JIA, and you can see some of the critical questions that I think we have to answer regarding the patient selection and when to begin a biologic therapy to have optimal outcome. A few years ago, Peter Nigrovich from Boston Children's published this review somehow highlighting the windows of opportunity in patients with systemic juvenile idiopathic arthritis, highlighting that the systemic JIA at early stage of the disease is more autoinflammatory disease, and then during the course of the disease transforms into a more, let's say, adaptive immune response with the Th17 lymphocytes. And this kind of a hypothesis of windows of opportunity was even additionally emphasized with the recent extraordinary good clinical response to anti-IL-1 treatment in patients with acute phase, in the acute phase of systemic juvenile idiopathic arthritis. We do suspect that similar window of opportunity might be also in place for other subgroups of juvenile idiopathic arthritis. Currently, our treatment approach is based on a step-up treatment strategy. Step-up treatment strategy means that you can see here the mainstays of our treatment for oligoarticular glucocorticoid injection, for polyarticular methotrexate and TNF inhibitor, and for systemic JIA, several of patients at our center would go into interleukin-1 immediately. So step-up treatment strategy means that we will start with one treatment. If this treatment will not be successful, so we would start with non-steroidal. If this treatment would not be successful, we will upgrade, slowly upgrading treatment approaches. With this treatment approach, none of the patients will be over-treated, but some of the patients will be under-treated. Under-treated will be patients that have aggressive disease that would have relapse. So this is a step-up treatment strategy. But with new biologic drugs, with new JAK inhibitors, with new medications, and we know that these medications have pretty good results in clinical efficacy, we are becoming more ambitious. We would like to recognize our patients who will not respond in this step-up treatment approach earlier and treat them more aggressively during the disease course. With this step-up treatment approach, it is also somehow, and based on the currently available drugs, we set these time intervals to reach the target. And what are our targets in the treat-to-target approach? Basically, we would say that in 3 months' time, we would like to see 50% improvement, and in 6 months, we would like to have inactive disease. This is not true for systemic JIA, where we would like to see resolution of fever in 1 week time. But because we are becoming a little bit more ambitious, and we are kind of exploring if also step-down treatment approach would be applicable for juvenile idiopathic arthritis, there are now certain studies that are exploring different treatment strategies. Step-down treatment approaches that you are over-treating a subgroup of patients, so you are starting with aggressive treatment at the beginning, if the patient is in inactive disease, you would remove this treatment. So if I'm saying if every child with juvenile idiopathic arthritis would get biologics up front, we would have less let's say, lets patients with active disease in a certain period of time, but definitely some patients would be over-treated if we would in every patient start with biologics. So these studies that are exploring step-up against step-down treatment approaches, some of the studies are already published. I would like to share this study that was performed as a CARA, observational patient registry study. So colleagues from North America, Canadian, US said that they will collect, according to a consensus treatment plans, protocols that are using step-up treatment approach and step-down treatment approaches. And you can see they had 3 defined consensus treatment protocols: step-up plan, initial DMARD, and then adding biologics, early combination, so biologics plus DMARD, or biologic first, and you can see the outcome measures that were used. The problem of this registry-based study was that there was immediately confounding factor that the treating physician decided which consensus treatment plan he will use in different patients. So it was not random for this juvenile idiopathic arthritis patient, but it was decided by the treating physician. And we tend to treat more aggressively patients with more aggressive disease. You can see that this step-up approach was used in 64% of patients, early combination in 25% of patients, and biologic first as a monotherapy in 11% of patients. I don't have a pointer, but if you see the 4th and 5th column are those patients with early combination and biologic first. They had more active joints at the beginning, particularly patients that were using combination. So the biologics and DMARD, so they had more active disease according to physician global, to parent global. They had higher clinical JIAs, and also number of joints were higher. What was interesting in this cohort of patients, that there were no significant differences between these 3 consensus treatment plans, and there was just a tendency, or this was statistically difference, that the percentage of patients with inactive disease according to JADAS-10 assessment of disease activity was higher in the early combination group. So kind of giving the suspicion that this combination gave the possibility to achieve inactive disease in higher percentage of patients. Basically, this study didn't show very clear differences between these treatment approaches. And I already mentioned that the major limitation of this study was confounding by indication of the treating physician. Probably some of you are already aware of the study that is ongoing, and we are eagerly awaiting the results of the STARS trial, which is a step-up and step-down treatment strategies in childhood arthritis. This is a study that was initiated by our Italian colleagues. It is ongoing in Italian centers, but the results of this study are not published yet, and were not all even presented at the congresses. These are data from our center regarding the success of methotrexate treatment in polyarticular JIA as a step-up treatment approach. So you can see that at least in our experience, methotrexate is an excellent medication. So we achieved inactive disease in 70% of patients and remission in nearly half of the patients. If we would use combined treatment with biologics, this means that 70% of patients would be over-treated with this approach to achieve inactive disease. But the thing is that in our clinical practice, we are already using biologics in certain subgroup of patients where we know that they have more severe disease or that they are more prone to have more disease-related damage. So we would use upfront biologics if there is cervical or hip involvement. If we have a patient with several joints involvement, if we are seeing skeletal damage on chest on X-ray imaging, we would immediately start biologics because we do not want to see permanent damage. If a patient has limited range of motion, if the patient has a prolonged disease course at the first rheumatology visit, or if the patient is rheumatoid factor positive. So this would be our confounding by indication if we would be, let's say, participating in the CARA trial. For the systemic JIA, I will just briefly mention because these protocols will be presented also later. There is a presentation on treatment of systemic JIA, but the thing is that the Dutch study on anakinra in new onset systemic JIA was definitely a game changer in this field of early treatment with biologics in the subgroup of patients with systemic JIA. We can comment that in this group, you can see inclusion criteria was really very low. Persistent of fever 7 days on non-steroidal anti-inflammatory drugs and already giving biologics. Anakinra is a little bit earlier in our opinion, but definitely we are also giving anakinra as a first-line monotherapy now in systemic JIA. The response rate in this subgroup of patients, we can argue that some of these patients might not have systemic JIA because you can see that out of 44 patients, 12 had no arthritis at onset. So it's not systemic juvenile idiopathic arthritis, but let's say systemic inflammatory group of diseases resembling systemic juvenile idiopathic arthritis, but none of the less, the response was dramatic. And if we look 3 months after the initiation of anakinra, 80% of these patients were in inactive disease state, which is a remarkable data on the early use of anti-IL-1 treatment. I would like to discuss a little bit on new treatment options, and I will start with biosimilars, not with JAK inhibitors and secukinumab, because biosimilars are really coming in our area because they are reducing costs and we are using more and more biosimilars. I would like to highlight that biosimilars, we do know that they have same amino acid sequence and biological activity, and this minor variability in glycosylation, it happens also in different batches of reference medicine, because these are biologic products, and also reference medicine in different batches is not completely the same. So it's pretty much the same as biosimilar. We do know what are the pros and cons. For the cons, I would say that we do not have enough pediatric studies, but these are slowly mounting up. I would like to share this data from the German BICAR registry, where they treated 348 patients with etanercept. You can see the numbers for originator and biosimilar, and they switched patients on originator with biosimilar, and there were no kind of a disease relapses. For switching of biologics, EMA does not regulate interchangeability, and this falls within the remit of each EU member state. So I don't know what is the situation in Romania, but this is the responsibility of each EU member state, and I'm sharing the guidelines and practice in Slovenia. We do have possibility to switch. In general, we do not switch originator with biosimilar. We prescribe biosimilars in naive patients, because if the drug is somehow working, we tend to keep the medication the same, either biosimilar or originator. I don't know, maybe in the future we will be switching even more common patients. In Slovenia, we estimate that we have approximately 550 JIA patients, and 35% of these patients are treated with biologics, which is somehow in line what is the number of patients that are non-responsive to methotrexate. So approximately 35% of our JIA patients are treated with biologics, and you can see the list of biologics that we are using. In adalimumab, we are using biosimilars in approximately 40%, in etanercept 10%. This is slowly rising, and for infliximab, we are using biosimilars, and you can see also for some other medications. In spite of the fact that we have biologics, there is definitely unmet needs. You can see in the upper part, in the upper row, the dark blue rows. These are patients who were exposed to non-registered biologic drug, either in the CARA registry or the Cincinnati Children's Juvenile Idiopathic Arthritis cohort. So more than between 15 and 20% of our patients, even with the best possible biologics, are still active, and we are searching for other medications. And we do know that targeting a single cytokine maybe is not enough in certain group of patients, and of course the idea is blocking an intracellular pathway would inhibit multiple cytokines, and we would be able to somehow get a disease control in subgroup of patients. And this is the logic behind the use of JAK inhibitors also in juvenile idiopathic arthritis, because the more than 50 cytokines that are kind of the main drivers of inflammation in autoimmune diseases use this JAK-STAT signaling pathway. We have different JAK inhibitors. I would just like to highlight that they have different targets. For example, tofacitinib is regarded as a pan-JAK inhibitor, while baricitinib is targeting particularly JAK1 and JAK2. So they have a little bit different target. Also, JAK inhibitors are not the same drugs, and I would like just briefly share the data from 3 studies that were recently published. One is tofacitinib in JIA withdrawal phase 3 trial, which was published in Lancet 21. They included 184 patients with polyarticular course JIA, 20 psoriatic, 21 enthesitis-related arthritis. They excluded patients with active uveitis. And this study showed good efficacy of tofacitinib with less relapse rate in the tofacitinib group with an acceptable safety profile. Just recently, in August, was published the baricitinib in JIA trial, also in Lancet. It was the classic design, withdrawal phase 3 trial, included 220 polyarticular course JIA. You can see all the different groups lumped into one large basket. These patients were inadequate or intolerant to at least one conventional synthetic, methotrexate, or biologic DMARD. And this study again showed the good efficacy with acceptable profile of baricitinib in JIA. Actually, the mean time to flare in placebo group was 27 weeks and was even not reachable in baricitinib group because less than 50% of patients had a flare event, which is pretty kind of a convincing data for baricitinib. The third trial that I would like to show is not a JAK inhibitor trial, but is secukinumab trial. We are using in some of our enthesitis-related arthritis patients and some of our juvenile psoriatic arthritis patients. The trial was published in Annals of Rheumatic Diseases this year. Included altogether 86 patients with enthesitis-related arthritis and juvenile psoriatic arthritis. In this study, they included only biologically naive patients. And you can see that the flare events in the secukinumab group were 27%, while in placebo 55%, which shows statistically significant efficacy with acceptable safety profile. Regarding the early patient stratification and predictive biomarkers, I would like to spend a few slides on imaging because I were not able, due to time limitations, to focus more on imaging, and a few slides on system biology approach. On the imaging, so together with one of our fellow who was recently, so from Siena came Maria Tarzia to our unit fellow, and she prepared a nice review together with our radiologist. We evaluated the use on imaging in juvenile idiopathic arthritis, which can also be transformative, not to confirm diagnosis. It's not kind of but more to decide regarding the treatment option, regarding the disease activity, disease relapse, and kind of a decision regarding the continuation of treatment or to change the treatment, because the diagnosis currently is clinical diagnosis. So what is our approach? Our approach is that we should use different imaging modality judiciously, depending on the involvement. For example, we would use MRI imaging for the cervical spine, for hip, for tarsal involvement. We would use ultrasound for assessments of tenosynovitis, for joint injections in the difficult joints, and we would use X-rays particularly to show if there are any skeletal damages in these patients. There are also kind of a more aggressive initiatives in the imaging world. So this was the OMERACT working group in juvenile idiopathic arthritis, evaluating and proposing whole body MRI scoring system for assessment of inflammation in JIA, but according to our opinion, this is not feasible in our clinical practice. Of course, this is kind of a very precise and sensitive measure, but basically, we would not change our treatment if the patient has 6 active joints or if the patient has 8 active joints, if the patient has 13 active joints. Our treatment decision would be similar with several joints involvement. And I think that this is even more too thorough investigation with whole body MRI in the juvenile idiopathic arthritis. Regarding the biology, system biology approaches, I'm sharing just one study published in Annals of Rheumatic Diseases on immunomic and transcriptomic signatures in juvenile idiopathic arthritis, recognizing a specific CD4 memory cell subset in immune checkpoint receptors. A similar study that evaluated checkpoint inhibitors in juvenile idiopathic arthritis were published in pediatric research by our Turkish colleagues, showing that these changes are particularly pronounced in synovial fluid in patients with juvenile idiopathic arthritis, where is actually ongoing local inflammation. We might expect that in the future we will be able to more precisely evaluate the synovial fluid and maybe decide also on the basis of synovial fluid cells what would be the right treatment approach in certain patients. I would like to finish with non-pharmacological management, immunization, medication monitoring, shared decision making, and physical activity. I did not include the slide, but the physical activity was shown that regular physical activity reduces inflammation for 30%. So actually, it's almost like some of the biologic drugs. So physical activity should be kind of prescribed like a prescription drug also in our patients. Regarding the vaccination coverage, I'm sharing just the data that are from our center regarding the percentage of coverage. You can see that so this was 2 years ago. Now we are much more proactive in checking the vaccination. Also, my colleague, Natasha Toplak, maybe you know some of her. She is really kind of very enthusiastic in checking the vaccination status in a group of patients. And I included this slide to show somehow how I see the future of treatment, that we do not have one single treatment for a group of patients with polyarticular JIA, and I will use the analogy like that somebody would be asking what is the ideal transport modality to come to Rheumatology Congress in Cluj. Somebody would say bicycles, somebody would say walking if they are living nearby. Most of you probably came by car or by bus, and I came by plane. And if you would try to convince me that the car is the best option to come to Cluj to the conference, I would not agree. And the same as for in this traffic, we need to somehow select for the different needs. We also need to somehow select the biomarkers and the right drug for different patients. And for different parts of this patient course, we might use different medications, so at the beginning or later. So I would like to conclude that targeted therapies, we are using this step-down treatment approach more and more commonly in our clinical practice based on our clinical decisions, based on the new medications that are coming. In active disease state is definitely a reachable target with the current treatments for juvenile idiopathic arthritis, and particularly for systemic JIA, with early treatment. And I would say that with precision medicine, we might expect in the future even more precise, maybe on synovial fluid or some more precise marker in serum to have even a kind of a more targeted treatments in the future. Thank you very much. I will finish with this picture from our hospital. Thank you very much.